Hi, I'm Meredith Bates, and today I'm presenting the article called Randomized Rater-Blinded Parallel Trial of Intensive Speech Therapy in Subacute Post-Stroke Aphasia, the SPIRIT study. The researchers of this article discussed speech-language therapy with clients who have aphasia. Previous evidence recommends that speech-language therapy is used as a best practice for aphasia recovery. However, variables such as amount, duration, type, and intensity may require further study. The researchers explored the subject of intensive therapy as compared to a more distributed dosage schedule. The authors explained previous research has produced contradictory results, in addition to issues of high-intensity groups receiving more total number of hours of therapy. In one review, an author commented on comparing studies of total number of hours. The researchers explored the subject. The researchers explored the subject of intensive therapy as compared to a more distributed dosage schedule. The authors explained previous research has produced contradictory results, in addition to issues of high-intensity groups receiving more total number of therapy hours. In one review, the author compared studies that received positive and negative results with speech-language therapy dosage. A minimum of 98 hours was required to show positive results. This was the basis the researchers used for choosing 100 hours as their total number of hours that would be used in this study. The researchers examined the performance of two groups of aphasia patients to determine which group would perform better, the intensive speech-language therapy group or the regular regimen of speech-language therapy. The sample included 30 participants randomly divided into two groups. Only 18 participants completed the whole study. Participants ranged in age from 40 to 80 years. They were all Portuguese speakers. Brain imaging results showed left hemisphere infarct of the MCA, and they all had AQs between 6 and 77. The reason they did this is that excluded the mild, the very mild, and the very severe aphasia types, severities. They used something called the Lisbon aphasia battery, which I'll talk about later, which is similar to the Western aphasia battery. And all of the participants were within the first 3 months post-stroke. The outcome measures that they used, the primary outcome was the proportion of responders in each group. The way they measured this was responders were anyone who had an increase of 15 AQ points or greater from baseline to completion, and this was assessed at 50 weeks. And the responder definition was based on the researchers' unanimous decision, and it was that they based that on their experience with this test. The secondary outcome looked at group differences. They compared the mean differences in AQ and the functional communication profile. Improvement consistency between weeks 50 and 62 were also looked at. Randomized assignment was used in this study to produce two groups, the intensity group and the regular group. Two severity categories were used in random assignment as well in order to control for initial severity. Evaluations were conducted at weeks 10, 50, and 62 by a neurologist or an SLP who was blind to the group. Assessments included the aphasia severity rating scale of the Boston Diagnostic Aphasia Examination, the Lisbon Aphasia Assessment Battery, which is comparable to the Western Aphasia Battery, the subtests of Portuguese versions of the Aiken Aphasia Battery, the Functional Communication Profile, and the Stroke Aphasia Depression Questionnaire. Therapy was individualized, however, the same therapy materials were used. Therapy included picture confrontational naming, naming from definition and description, describing pictures, phrase completion, yes-no questions, why questions, retelling daily news. There were 100 hours of speech-language therapy, and this is something that's important for this study. In the two groups, they both received the 100 hours. However, it was distributed differently. The intensity group received 2 hours per day 5 days a week for 10 weeks. The regular group received 2 hours per week for 50 weeks. So very different methodology. However, they both received the same amount of hours. A number of statistical analyses were used in this study. Both non-parametric and parametric tests were used. The non-parametric tests included the chi-squares, Mann-Whitney-U tests, and the parametric tests included independent samples t-tests and paired t-tests. The non-parametric tests were often selected when assumptions of normal distribution were not able to be made. The parametric tests were used when normal distributions could be assumed and when means were used to compare the two groups. I've listed the tests that were used. The chi-square and Fisher's exact test were used for categorical variables, such as the responders and the non-completions. And the independent sample t-test and Mann-Whitney-U tests were used for continuous variables, such as the mean group scores that were compared from the baseline. The paired t-tests were also used. They compared the subject's response stability, and the mixed design repeated measures ANOVA was also used for within and between group comparisons. And they were comparing the AQs and the FCP scores. There were 30 participants at the beginning of the study, but only 17 completed the entire 50-week study. The primary outcome measure was the proportion of responders, and there were no significant differences between the two groups. The secondary measure, if you remember, was the AQ and FCP scores, and they were looking at the mean differences between the two groups, and there were no significant differences between the groups. There was a significant increase in AQ from the baseline in all treatment patients except for one, but there was no interaction with the AQ increase and the treatment groups themselves. So which group they were assigned to, that was not showing up as a variable that affected the outcome. One thing the researchers did that was important was at the end they restricted the sample size only to the patients who completed the study, and they did find higher score changes seen in the IT group, which is the intensity group. This figure shows a flow chart that shows the participation of the study, and the chart shows some of the issues that the researchers had that they encountered when doing this study. If you look at the top, it says that they started out with 182 participants that they assessed for eligibility, and if you look down at the bottom, we're only left with 14. The initial exclusions included in the initial exclusions that the researchers used, if you can see at the top, was they looked at the AQ score and they limited it, and so by limiting it, by not having the very, very severe or the very, very mild participants, that took away a lot of participants right there. Other exclusions include refusal, transportation issues, and transferring to another center to be treated. The study also, as the study progressed, other participants withdrew from the study, and some of the reasons were missing evaluations, and also illness, transfers, or death. All of these factors contributed to the small sample size of the study, which was important. Conclusions. Despite the lack of significant differences between the groups, there was a tendency for the intensity group to make larger and quicker gains than the regular group. The smaller sample size may have contributed to the lack of significant results. When looking at the intensity group, it was seen that at the end of treatments at 10 weeks, when they completed their therapy, but you remember the other group actually continued on for a total of 50 weeks. But when this group ended at 10 weeks, their benefits that they had already received from the therapy were maintained over the following weeks of the study. And also there were small improvements that were made as well during that time. So the researchers said that this has implications for neuroplasticity when you're looking at the combination of this specific type of treatment. So they recommended further study in that area. Also, there were implications for therapy gains for chronic aphasia patients as well, due to the fact that you could continue to do some therapy on your own at home, do practice, or do extra therapy beyond the intensity time period. So further clinical implications for both of those. When looking at levels of evidence, This study was a 1B, which is a well-designed randomized controlled study. And the way that it accomplished this is it controlled for variables such as depression, initial aphasia severity, and the total number of hours, which was 100. And it also used randomization between the two groups. The strengths and weaknesses of this research article. Let's look at the strengths first. They included the equal number of treatment hours, which again we've talked about. That was something that was different that the researchers wanted to look into. Previous studies had not controlled for that, and so usually what happened was the higher intensity groups received more therapy hours total. So it was hard to determine if it was the intensity or if it was the total number of hours. So this study did control for that. Another strength was randomization of the patients, controlling for initial severity and depression. Consistent therapy was used. They used stimulation therapy, and that was consistent in both groups. And the implications for further study on intensity and neuroplasticity. So that's a positive of the study. It could lead to other things. The weaknesses of this study included the small sample size and the fact that a high number of patients withdrew from the study. Another weakness is the subacute period post-stroke also can correspond with your natural recovery time. So it is kind of hard to separate those two, so it's hard to control for that natural spontaneous recovery. And the last weakness of this study is the primary measure could also be changed in a future study so that it's not a predetermined number. So if you remember, the primary measure, outcome measure, was looking at the responders, and it had a specific number that it used that all the researchers agreed on, that if you increased by this amount in your AQ score, then you would be classified as a responder. So instead of that, they were recommending, well, next time, what if you were to not use a predetermined number, but see the exact amount of change? And so that might actually show a measure of magnitude of change between the two groups. And it might also help with looking to see if you could get statistical significance by looking at that variable. So that was a weakness that could be improved upon. And last, these are my references, and that's it. Thank you.